I will be, if you just pardon me one more second. There, that should be the last of the interruptions. I will be talking today about another facet of psychosis, or another fact of psychosis, and that is that psychosis is not necessarily a psychiatric symptom. In fact, I think it is more accurate by a long shot to view psychosis as a neurological symptom that is a non-specific symptom. In fact, I think psychosis is probably the best analogy for psychosis is, well, I don't know about the best, but a reasonable analogy for psychosis is fever. It's something that's fairly easy to recognize, and it's something that signifies disturbance in a variety. It has a variety of different pathways. So it technically is a standalone diagnosis, fever and psychosis. Each of them have their own specific ICD code. So you could get away with ending a session saying the diagnosis is fever or the diagnosis is psychosis. And you could technically reasonably alleviate the symptom by prescribing an NSAID in the case of fever, or an antipsychotic in the case of psychosis, but you kind of sell the patient short, because at the end of the session, you're still left with the big and most important question: what is the cause of that non-specific symptom, which really is not, in the best sense, a diagnosis by itself. It is something with a broad differential diagnosis that requires some thinking and actually kind of a vigorous workup before ever deciding that the psychosis is the result of a psychiatric condition. In the very broadest 36,000-foot overview, psychosis can be seen as resulting from three classes of cause. I call them chemical psychosis, medical psychosis, and psychiatric psychosis, with the asterisk that psychiatric diseases actually are medical diseases at their ultimate core. It's just we don't understand very well what that ultimate core looks like. So because they remain medically idiopathic, they get this name, an unfortunate feeling of separateness that's called psychiatric. So, but aside from that, we'll call them psychiatric for now. So chemical, medical, and psychiatric. In chemical, I won't talk about that today, but suffice it to say that I stopped counting, but my last count ended at about 100 therapeutic drugs that have psychosis as a side effect, and not counting recreational drugs that can have psychosis as a side effect, either as a direct effect of their use or as a withdrawal effect. And non-medical diseases or psychiatric conditions, at least 6 that can have psychosis as part of their symptom course. And medical psychosis, meaning non-psychiatric medical diseases, the kind that most physicians would count as medical. And within the medical family, almost anything. I took a stab at trying to break them into broad categories of illness, and here's what you get: autoimmune, endocrine, genetic, infectious, neoplastic, neurologic, and nutritional. Some of the entities could cross various categories, and in the end, I also stopped counting the number of medical entities. I stopped my count at 50 of them. And when it comes to medical exam, I tell people there's no such thing as a focused physical exam for ruling out medical causes of psychosis, because medical diseases that can give rise to psychosis can occur in essentially any organ system. So it does really require a head to toe, very careful evaluation. And now, as you know, I sometimes get snarky. And why I get snarky is because I've seen more than one example of people that have had that never should have been labeled psychiatric patients, that never should have been given antipsychotic drugs, that never should have, for example, been, going to group homes or involuntarily hospitalized, who should have had, say, their brain tumor recognized 3 years ago before they lost consciousness and fell down and so forth. So I do get a little bit testy about the readiness with which the system assigns psychiatric causation to psychiatric problems, or to so-called psychiatric problems. So to now get to a bit of snarky aside, no, I'm going to come to the snarky aside in a little bit. It's going to fit in better in a few minutes. Medical causes of psychosis, as I alluded to, can quite often be missed, because in some of the medical diseases that can present with psychosis may be the very first symptom before any other discernible physical sign or symptom is noticeable. In other cases, the physical signs or symptoms actually are present, but they pale in comparison, or they don't attract nearly enough attention, or to put it even better, the psychosis attracts so much attention that the thing like the cognitive impairment or the attentional impairment or the clumsiness gets forgotten about, or the cognitive impairment gets ascribed to the psychosis, because it passes as common knowledge that lots of people, maybe almost everybody with psychosis, has cognitive impairment. And so if a person has memory problems, those memory problems are quite often assumed to be secondary to the psychiatric, or to the supposed or the assumed psychiatric condition. And then when that happens, in many cases, this has been the case, that the autoimmune encephalitis didn't get recognized until the person has had seizures. So again, these are examples of things that make me a little bit testy about this topic. And there's more where that came from. So there is as well an extraordinarily strong cultural bias that is probably about 5,000 years old, toward assuming that things that affect our thinking or our behavior must be, psychiatric, or don't really count as medical or biological in origin. And then this last one, many patients who present with primarily, or seem to present with primarily, or when they hit the triage office or the triage person, the only complaint that's given is suicidality or voices or what have you. They get triaged to the psych section, and then the exams can be way superficial. And there's an ongoing, like, 100-year debate in psychiatry whether the psychiatrist or the mental health professional ought to ever do any kind of very serious physical exam, because it requires, as this audience very well knows, a significant amount of intimacy, of physical contact, of touching and looking, and physical closeness. And it's a debatable it's a debatable concept, but there are good reasons to be worried that the physical closeness of a physical exam might interfere or confuse the necessary emotional closeness or psychological intimacy that needs to be developed to establish the rapport, to try to get at psychological evaluations. Like, I don't think there's a clear yes or no right answer to that, but so it's a legitimate point of concern or debate. And the vast majority of psychiatrists have sided with we probably ought not to touch our patients a whole lot. So the culture in psychiatry is probably not very much to do that. So the mental health people tend not to. And from my observation, my personal observation of how things are organized in these modern times, is that with significant frequency, at least in psychiatric hospitals, in state hospitals, in many outpatient mental health centers, what they tellingly refer to as the exam piece gets outsourced to a contracted medical provider who comes in maybe a half day a week and then does the piece on everybody that's been enrolled in the last period since the last half day assignment. And then sadly, not infrequently, the role of doing the medical piece is given to people who are not long out of school and don't really have, I don't think have a lot of training or experience or have developed a high level of suspicion to notice subtleties or to try to link physical abnormalities with psychiatric things. So there could be a lot of reasons why physical signs are missed. And now I can't help, God, I can't help. I'm sorry. So there was in fact, in my own consultation practice, there was a case in which a woman in her mid-20s had a glorious development and was doing quite well. There was nothing abnormal at anything up until mid-20s, where according to seemingly very well-informed mom, the patient started becoming extraordinarily forgetful. And then because of her cognitive impairments, which were way out of character, this became very frustrating. And then alongside the uncharacteristic forgetfulness became also very uncharacteristic anger and frustration. So the presenting signs were cognitive impairment and debatably emotional lability or irritability or agitation. And that was given some psychiatric diagnosis, which pretty quickly became a schizophrenia diagnosis. And that was, she was sent into the mental health system for, thankfully, a brief period of time until somebody discovered an abnormal thyroid stimulating hormone. And then that was followed up. Thank God, somebody actually asked a question, why does this young woman have a high TSH value? And they got, and I say thank God, because in my experience, so many psychiatric patients have high TSHs and nobody actually asks, why is it high? And they did follow up with a thyroid peroxidase antibody. She got a diagnosis of autoimmune thyroiditis, was then given steroids. By that point, however, she had deteriorated so badly that a court awarded guardianship to mom. And with the steroid treatment, the patient was restored and parents were comfortable with dropping guardianship. And then eventually the exact same symptoms came back. And then she, then regrettably, the doctor who made the correct diagnosis the first time found that the TPO antibody titer was not elevated this time around and concluded that there was not any active thyroid disease present and said that steroids were not indicated. This was not anymore any form of autoimmune disease and said this must be a psychiatric problem. At which point, sad to say, I think it was 3 more years passed when she was nothing but psychiatric care, and a parade of schizophrenia, schizoaffective, or bipolar diagnoses were made with several psychiatric hospitalizations and a sequence of antipsychotic or anti-manic drugs, none of which were helpful, arose, and so on. So during all this, the patient went to a neurologist at a academic medical center of high reputation. And reportedly, according to mom, the patient had a tremor by that point. In other words, a neurological sign, in addition to the cognitive impairment. And the neurologist said that apparently the neurologist asked the patient if she was cold, and the patient said yes. And based on that, I assume that the neurologist wrote off the tremor as coldness. And in the end, I looked up the guy's name, and he wrote a paper in which he writes, this guy allegedly writes, you can't go by laboratory values. You have to go by clinical picture in order to diagnose autoimmune encephalitis. And he wound up like apparently missing a case of autoimmune encephalitis or dismissing it. And then there you go. So like I said, a very strong bias to assuming psychiatric origin, even more so when medical presentations are not like the textbooks say they ought to be line by line. And now to get another snarkiness, it's more than fantasy. I will write an article. The title is debatable, but the working title is, would we recognize medical causes of psychosis if they bit us in our ass? And what I mean by that is that, autoimmune encephalitis causing psychosis is not very common. And if you are an endocrinologist or a rheumatologist or a neurologist who specializes in neurological diseases that affect behavior, you probably don't see that many cases. And I doubt that every case of autoimmune encephalitis that presents with psychosis is going to line up with what your textbook says it ought to look like. And so this poor young lady was stuck because none of the psychiatrists in my profession were willing to think outside of their box. And the handful of medical doctors that she encountered didn't really apparently think about that there might be some variations beyond the classic textbook descriptions. And that was her problem. So this story ends with, I did find a doctor in her area who did seem to be interested in her case. And the last I heard, she was signed up for intravenous immunoglobulin. And I have yet to get a feedback from the mom about how things are going, but I'm hopeful. Okay, sorry about the digression, but hopefully that was, in addition to entertaining, somewhat useful. But this is a longstanding concern. Back in 1936, Dr. Comro wrote, and I love this phrasing, it's popular malpractice to relegate those patients with a somewhat bizarre symptom complex and without significant evidence of organic disease. In other words, those patients in which you don't find very obvious physical abnormalities, but present with unusual, primarily psychiatric symptoms, to just call them neurotics, which in 1936 could have meant almost anything. But alarmingly, the people in 1936-ish who were given a psychiatric diagnosis, retrospectively, within an average of 8 months, had about a quarter of them had a medical physical illness, which in hindsight, their psychiatric illness probably was the lead presentation of it. And maybe we're not a whole lot better. In 1968, Johnson found that 1 out of every 8 patients that it was admitted to an inpatient psychiatry ward had a medical cause of their psychiatric symptoms. And I didn't write down that, but at least 25%, I want to say maybe nearly half of them, were missed initially. And in a first episode program in the United Kingdom in the late 1980s, more than 1 in 20 patients had a medical cause of their psychosis. According to Falchi, this is somewhat debatable, and Falchi is probably an outlier toward the upside, but Falchi argues that maybe up to 1 in 10 people with schizophrenia have brain lesions that are probably relevant to the psychiatric presentation. At Kluba, working in an emergency department in South Africa, Johannesburg, so urban academic medical center, found that quite a large number of people coming in with psychosis had a medical cause. Then I'll show you some more data. Well, Henneman I don't have, but looking at first episode psychiatric symptom, not just psychosis, but all any psychiatric symptom, but first episode, 60% had medical origin. And in the study by Hall, 60% of people that came into a psychiatric receiving center for either Dallas or Houston turned out to have a psychiatric origin. The Hall study is particularly sad because it was, like I said, it was either Dallas or Houston. I think it was Houston, and it was a common model where there's a central receiving it's like a psychiatric emergency room hospital. So ambulances or police would bring people in crisis to a central location, and in that location, those that were in need of admission were then offered a chance to go to a specialized research ward. According to the authors, the people that were offered the chance to go to the research ward probably would have ultimately wound up in a state hospital. So these were people that were in need of hospital care, that were deemed serious enough to probably, ultimately be state hospital patients, who would have, were it not for their being offered this special chance to just basically get a standardized medical evaluation, would have gone to state hospital, where I can guarantee they would not have been given a standardized medical evaluation. It was not a super elaborate one. They basically got complete medical exam, neurological exam, 34-item laboratory panel. They did do an EEG, which was atypical. They did like a complete a life history and some questionnaires. I mean, it was not really, aside from the EEG, not particularly expensive or esoteric or time consuming. And they found 60% of these people with medical problems, medical diseases, that probably would have gone undetected. So this is a gigantic, this is why I get really pissed. And so anyway, what were the diseases that were discovered? So in the Johnstone study, the UK first episode clinic, syphilis, drug alcohol, sarcoid, lung cancer, autoimmune disease, sister psychosis, I was shocked, thyroid disease, and head injury. Johnstone did a different, same people, but different setting and different year. This was outpatient, first episode schizophrenia. This was inpatient, adults with psychosis, similar incidence, roughly similar, 7%. And the underlying medical conditions were, again, alcohol, drug, thyroid, syphilis, tumors, stroke, lung cancer, again, autoimmune disease. I assume steroids were the cause in the ulcerative colitis patient, B12 deficiency, and I really don't know. They didn't elaborate how uncontrolled diabetes led to psychosis. I didn't know that was possible, but that's what they said. So that was that. And in that Hall study, the one where they found that more than half of people that would have otherwise gone to the state hospital most likely had a medical disease at the heart of it. By the way, they also commented in that paper that simply treating the medical condition resulted in a rapid elimination of the psychiatric symptom in 60% of the cases. So that really is the exclamation point, that the medical disease, which was never detected until these guys went looking for them with a relatively simple battery of tests, was relevant. So these were the things that they found. And here they just broke them down into the subcategories of disease. But vitamin deficiency, thyroid disease, anemia, hypoglycemia, Wilson's disease, syphilis again, anemia. Some of these I don't know how they got. I don't think the peptic ulcer was the cause of psychosis, but they found it there. Pick's disease, that probably was relevant. Addison's disease, probably relevant. Pneumonitis probably would have exacerbated, although it could have caused psychosis in somebody with a vulnerable brain. So the point is, medical diseases are common, and they can either directly cause psychosis, or in people with other neurological vulnerabilities can certainly tip one in the direction. And in the South Africa study, where these were the medical causes that were detected. So, a lot of this is not difficult to detect if, again, you simply look. And this then explains why you can probably detect in my voice a little bit of saltiness, because I have been told since my medical school days, and it says in every chapter of DSM, don't make a psychiatric diagnosis unless you have ruled out a medical cause of these symptoms. So this seems like the most basic and the most obvious thing, but yet urinary tract infection, pneumonia, epilepsy, thyroid disease, syphilis, renal failure, stroke, these are not difficult things to detect, oftentimes by just basic physical exam or asking questions about medical history, or by doing some simple and not expensive laboratories. But I mean, I can guarantee you from having been a consultant psychiatrist who reviews a lot of laboratories in people who don't get better, these are like so often missed. So thanks for inviting me here, and thanks for being here, because one thing I know about primary care clinicians is that you guys can order tests. so I'm going to tell you tests that can be ordered. The other thing that just like blows me away is that in an era or at a time in history where almost every disease comes with an algorithm or a pathway, like here you have coughing, here's a pathway including a bunch of recommended tests or diagnostics you can run. That for schizophrenia or for psychosis, nobody has come up with a really clear pathway, like to say what would be the American Psychiatric Association's psychosis medical workup pathway. It just does not exist, and there's not really consensus across any group. There have been some attempts by various people to come up with something, and so in the book, Jamie, I sent a link to you. You can send it out, but if you go to bit.ly/psychosis book, you can download this thing. I mentioned it last time I spoke, but this is from that book. I did summarize 4 kind of major attempts to come up with some list of tests, and you can read. I mean, you can just see what people wrote. I put these together, and this is the list I come up with that makes sense. They include sort of no-brainer things that in which there was universal agreement: CBC with differential, electrolyte, calcium. Basically, all these electrolytes, calcium, renal function, liver function, lipid panel, fasting glucose, you can get all with a comprehensive metabolic panel fasting. Thyroid hormone, TSH, yes, absolutely, please. I do think that thyroid peroxidase antibody would be high value. It has high sensitivity to detect autoimmune thyroiditis, but it also unfortunately has a high false positive rate. So although you get 95% sensitivity for autoimmune thyroiditis, you do get, by some estimates, 20% false positives. So if it comes up positive, you have to do some additional thinking. But I think it's probably better to err on the side of false positive, because this is easily treatable with steroids, and if not caught, can result in permanent cognitive impairment if it has CNS involvement. C-reactive protein and sed rate I like, and other people's have recommended, because these are just broad screens for inflammation, and a major cause of psychotic symptoms is a host of inflammatory diseases. ANA, again, a screen for autoimmune disease. There is several labs now offer something that broadly goes, and there are different names for it now, but they call it encephalitis panel or so on. They include anti-NMDA antibodies, anti-voltage gated potassium channel antibodies, and anti-glutamic acid decarboxylase or anti-GAD antibodies. These are neuronal antibodies, and the NMDA receptor antibody is the lady that wrote Brain on Fire. She had that. I think the autoimmune encephalitis panel, you can get it in serum for one thing. It has over 90% sensitivity in serum. CSF has higher sensitivity, but is obviously hugely problematic, or much more difficult to get. So serum is probably adequate for screening. It's, I think, valuable for first episode psychosis or relatively recent onset psychosis. And particularly in somebody who's young, and most particularly in a young woman or girl. If psychosis has been present for more than a year, it's almost certain that there will be neurological signs present by that time. So if you simply if you have somebody with chronic psychosis and you do a very thorough neurological exam and you find no abnormalities, including no cognitive abnormalities, then, I mean, it doesn't hurt to do the panel, but if you're looking to save time or trouble or cost, then you could skip it. Although I didn't check recently, I checked about a year and a half ago. I called, which I like, I called the specialty lab in Utah, and they quoted me a retail price of $120. So it's not, and that was like cash paying customer, not an insurance discount. So it's not, it probably is more expensive now, but you know, it's not a giant cost. Nobody has recommended these officially, but I put these in if I'm given the opportunity to order panels. Tissue transglutaminase is a fairly sensitive screen for celiac disease. There have been case reports of individuals presenting with symptoms that sound very much like schizophrenia, who were unsuccessfully treated with antipsychotic drugs for many years before intestinal symptoms presented, at which point celiac diagnosis was made and gluten-free diet resolved the psychosis. And in in a very large study, a spin-off of the Katie study, Katie was a very large NIH-sponsored trial that involved 1,000 individuals with schizophrenia. They also did they did a whole bunch of blood tests, and one of the spin-offs of the Katie study, which is primarily designed to test antipsychotic effectiveness, they compared 5 antipsychotics head-to-head. They also, in a spin-off, measured tissue transglutaminase and gliadin antibody titers. Gliadin is a wheat protein. And they found that elevated titers of TTG and gliadin were 7-fold more likely in the schizophrenia sample compared to the control group. So I think that's very interesting. And that is, like, we'll call chapter 1 of this little story, and chapter 2 of this little story is that there's it's a tiny literature on dietary interventions for schizophrenia, but that tiny literature, if you look at it in totality, is the majority of studies suggest that either a ketogenic diet, which is essentially it's most usually a gluten-free diet, or gluten-free or grain-free, dairy-free diets, that those kinds of dietary interventions may have some benefit in people with schizophrenia or bipolar disorder, according to some case reports. So it's not big evidence, and it's, of course, not even in the results, but there is maybe a signal there. So my thinking is, if there is a significant, if the person is tissue transglutaminase positive, then this person's psychosis may be the first presentation of celiac disease. So then the next step would be endoscopy and, you know, confirming a diagnosis of celiac disease if present. If they are gliadin positive, this means that their body has seen, their blood has seen wheat protein, which they shouldn't have seen. So I guess that means leaky gut. It certainly raises the possibility that gluten-free diet would be helpful. I don't usually recommend gluten-free diet just for anybody, but if there ever was a case I would, then this would be that person. HIV and syphilis, you know, they're out there, and as you saw in the data I showed you, it shows up with some consistency in samples of people with new onset psychosis. Cheap and sensitive tests, FTA. There are FTA and RPR are the tests for syphilis. FTA is durable. I mean, if a person's had syphilis, it will be positive for a really long time, and by the time syphilis causes psychosis, it usually has been a long time. So you want to use FTA as the screening method. Ceruloplasmin will be a screen for Wilson's disease, pretty rare, but also extremely treatable. And it's another one of these things like autoimmune encephalitis that if you catch it early, you can treat it effectively and rescue a person. But if you miss it, then by the time you catch neurological signs, you might wind up with permanent neurological damage. So it's cheap, sensitive, and I think because of that, should just be a default screen. Drug tests, as you saw, can be, drugs can cause psychosis. And so it's good to get, and the brain imaging is a point of great contention in the field of psychiatry. The argument against brain imaging routinely is that you'll catch a lot of abnormalities that are irrelevant to psychosis, and you will wind up, some of those abnormalities will be things that you can't do anything about. So you'll give patients or their families just stuff to worry about. In some of those abnormalities, you will think that they might have some relevance, and you might be tempted to do some intervention, which will come with some risk. And then you'll, but then if it turns out to have been irrelevant, then you will have exposed people to damage unnecessarily. And then, of course, most people will have no abnormalities, and it'll be costly, and you'll do a lot of screens for, and a lot of cost for no real good yields. So there's that. On the other hand, there are overrepresentation of meningiomas in frontal cortex and temporal cortex in people with psychosis, and those probably are relevant. And then there is things like stroke and tumor and cysticercosis or sarcoidosis, which can be detected, and so on. So it's an unresolved question. I side on the idea that everybody should, and that probably it's better to know what is there and then do the worrying about it, rather than to be caught off guard when whatever is there, it gets bigger. So that's the stories on that. And I've taken up a lot of time, so I guess I'm sorry about that, but hopefully that will have been helpful. And I'm done talking. So